Shrink Wrap Radio. All the psychology you need to know, and just enough to make you dangerous.
Shrink Wrap Radio number 66, What Really Works in Therapy, December 14, 2006. Welcome to Shrink Wrap Radio, the planet's premier psychology podcast. This is your host, Dr. Dave, coming to you from the San Francisco Bay Area. Shrink Wrap Radio is the show that speaks from the psychologist in me to the psychologist in you, whether you be amateur, student, or professional.
There's great evidence that what clinicians do works. In fact, the average treated client in most studies is better off than 80% of the untreated sample in those studies. And it gets obscured in this fight over which approach is best for this particular treatment condition that has only intensified in the last 10 to 15 years. You know, therapists have fought for most of their history about which treatment approach is best. You can trace this all the way back to the fallout between Freud and Jung and Adler, all the way forward to the battles between the cognitive people and the behavioral people, the brief therapy groups, etc. So this is not something that's just started. It's something that continues.
That was the voice of my guest, Scott D. Miller, Ph.D., noted author, psychologist, and workshop presenter. He's a therapist, lecturer, and trainer on client-directed, outcome-informed clinical work and other time-sensitive therapeutic approaches. For 3 years, he co-directed Problems to Solutions Incorporated, a clinic specializing in the treatment of the homeless and other traditionally underserved populations. Most recently, Dr. Miller co-founded the Institute for the Study of Therapeutic Change and works pro bono at a clinic dedicated to serving the underserved. He is the author of many papers and 7 books, including The Heroic Client in 2000 and The Heart and Soul of Change in 1999. Here's the interview. Dr. Scott D. Miller, welcome to Shrink Wrap Radio.
Thank you.
I've been reading your book, The Heroic Client, Doing Client-Directed Outcome-Informed Therapy, and I'm really excited by it. You and your co-author, Barry Duncan, do a marvelous job of combining passion and scholarship, and I love the in-your-face, take-no-prisoners style in which you guys take on the medical model, psychiatric diagnosis, the over-reliance on psychotropic medications, and the whole managed care industry. So let's step through some of that. Now, the medical model supposedly frees us up from prior belief systems in which clients were seen in terms of either demon possession or moral flaws of some sort. It supposedly removed the moral stigma and moved us to a place of, well, Joe just has a mental disease. It's not his fault any more than coming down with diabetes would be. So what's your take on the pluses and the minuses of the medical model?
Well, I think that the idea that we're talking about here is that the diagnosis a person has, and in our case, in this context, the American context, that is the DSM-4 diagnosis, tells us which particular treatment approach we should use that will lead to the best treatment outcome, and that simply isn't the case. There is, in fact, very little or no evidence that the diagnosis a person receives is correlated with the outcome, much less that it tells us which treatment approach is best. And yet, in the current zeitgeist, we've got this whole notion of evidence-based practices, which is the idea that there are certain treatments that are best for certain kinds of diagnostic conditions. And we're arguing that the data doesn't exist.
And that's based on a lot of research, right?
It's based on a ton of research, actually. What's surprising is how easily the field has been caught up in this whole notion of evidence-based practice, which we think are for reasons largely unrelated to the research, dating all the way back to the 1980s when psychiatry began to form consensus committees that said that for this particular condition, these are the appropriate ethical treatments that you should be doing. APA was very upfront about it and said, we're letting the other APA beat us to the punch, so we have to have something similar. They formed the task force on the promotion and dissemination of psychological procedures, which began to create and generate lists of treatment approaches for which there was evidence that they worked. Now, there's nothing wrong per se in that, except to say that the evidence not only says that these treatment approaches work, but there's not a hill of beans difference in terms of the outcome. So it really doesn't address the question about whether or not these treatment approaches are best for a particular diagnosis. But that's exactly how the public has understood it, and that's exactly how practitioners have understood it, and that's exactly how continuing education activities run, that for this particular treatment condition, this treatment approach is the best.
In your book, though, you review 40 years of research, and your findings suggest that people who are trained in using these diagnostic systems can't even agree on the diagnosis, that they have very low, what we call, reliability.
Right. If there were inter-rater reliability, that would be one thing. The major problem with the DSM is that it lacks validity, however, that these groupings of symptoms actually mean anything. And that data is completely lacking. If people use very careful, structured interviews, you can increase inter-rater reliability. But if they were not related to the outcome, then what are we really doing? Mm-hmm. We're clustering symptoms together, much the way medicine did in the medieval period. This is the way we treated people and thought about people when we talked about them being phlegmatic, for example, or the humors that they had. And essentially, they were categorizing illnesses based on clusters of symptoms. Now, at some point in the future, there may actually be a diagnostic system that is similar to what happens in medicine, where the underlying pathogenesis or etiology of the problem is identified, and then the treatment would be tied to addressing that particular pathogenic process. But we are light years away from that as a field.
Mm-hmm. Well,
which is not to say, by the way, and I think that, usually when I talk about this, it generates alarm on both the provider and the consumer side that somehow or other what therapists do doesn't work. In fact, the data are equally clear here, and this is the part that we find so surprising and talk about in The Heroic Client as well as in our book, The Heart and Soul of Change, that there's great evidence that what clinicians do works. In fact, the average treated client in most studies is better off than 80% of the untreated sample in those studies.
That's good news.
It's incredible news.
Yeah.
And it gets obscured in this fight over which approach is best for this particular treatment condition that has only intensified in the last 10 to 15 years. Therapists have fought for most of their history about which treatment approach is best. You can trace this all the way back to the fallout between Freud and Jung and Adler, all the way forward to the battles between the cognitive people and the behavioral people, the brief therapy groups, etc. So this is not something that's just started. It's something that continues.
Yes, yeah. It seems like psychology has really been co-opted by managed care in the medical model. I personally quit private practice in part because managed care presented so many hoops to jump through in terms of limiting the number of sessions and having to assign diagnostic categories that I didn't believe in. And I know other clinicians who kind of, they're in that situation of using these diagnostic codes just as a way to keep the treatment going. It's pretty widespread, isn't it?
Well, I'm of two opinions about all of this, and I think that managed care, frankly, and I'm no spokesperson for that particular industry, but they in essence, all they've done is enforce what clinicians have been saying matters. If you go to a staffing at any local agency and you listen to what's being said, when they talk about a case or a client, generally the first thing out of the clinician's mouth is A, what the diagnosis is, and B, what the treatment approach is that they're using. So we can't have it both ways. We can't complain both about managed care's reliance on these things and then use them in our day-to-day clinical work. They either matter or they don't. Mm-hmm. The data say those things really don't matter in terms of predicting outcome for the individual client seated in a clinician's office on that day. So, it's a chicken-egg problem for me. Who started this? I don't know. But everybody's paying the price for it.
Right.
And the industry, frankly, knows that diagnostic groupings don't predict very much. Less than 1% of the variance is attributable to the diagnosis a clinician puts on their HCFA 1500 form. And yet there are other things that do predict that we just seem to ignore.
When you say less than 1% predicts what? Predicts success of
the outcome variance, yes, okay. Or in this case, success, change in the client.
Okay.
And yet we spend huge amounts of time deciding what the diagnosis is, And managed care, of course, spends huge amounts of resources reviewing those files and treatment plans to see, do the goals fit with the stated diagnosis, and is that in any way related to what the expected course of treatment is?
One of the early chapters in the book is titled Mental Health at the Crossroads, and you wrote that in 2000, and it's now 7 years later. Are we still at the crossroads, or is it in some respects too late?
I don't think it's too late. We actually revised that book in 2004, but I think that much of what we predicted in the first edition of that book has in fact come to pass. In January, the very influential and widely read journal called Psychotherapy Finances, which looks at what's it like to work in this field at the present time financially, talked about a turn downward in clinicians' ability to maintain their lifestyle and their living. And in fact, it's not good news. I have to tell you, when we wrote the book in 2000 and we would go out and talk about this, generally we were poo-pooed, People would listen to us and say, the sky is in fact not falling. Well, now it is. And of course, each time in 2000, people were saying, well, I'm just shifting more of my practice towards self-pay clients. And we predicted in the book in 2000, the first edition, that this was not sustainable as a source of income. And as a matter of fact, Psychotherapy Finances comes out in January of this year, 2006, and says it's not sustainable. There's a huge downturn, probably close to 60-70% fewer clients willing to pay for treatment services out of pocket.
So it sounds like it's hard times for psychotherapists in private practice.
Oh, I think it's incredibly hard, and it's not just for therapists in practice. If you work in an agency, you are now inundated with an increasing amount of paperwork and regulation, which in some instances eats up to 60% of clinical time. So 60%, more than is actually spent helping the consumers of mental health services, is spent with clinicians sitting at their desk dealing with payers and funding forms and paperwork.
Exactly. That's what drove me out. Now, I think
let me give you an idea about why I think that is, and this is the argument that we make in Heroic Clients, that we are using as criteria for success things that have no bearing on success of the case. So, for example, diagnosis and treatment approach and treatment planning, these things are largely unrelated to outcome, and yet clinicians' time is being spent doing that. We all act like it matters. The result is that the paperwork gets turned in, the funders review it, and they tighten the controls, and that doesn't seem to lead to more efficient utilization of resources. So what do? They're left to believe that obviously they haven't tightened the controls enough. And the result is more paperwork, oversight, and regulation. And this spiraling pattern is the tyranny of escalating sameness that we're all operating under right now.
Yeah. I think your book makes really important points about what's broken in the so-called mental health system, but I'm wondering if it's preaching to the choir, or if you've been able to have any impact on the policymakers, for example, in the American Psychological Association.
Well, here again, I'm gonna put the burden of responsibility on the people who have it. Policymakers are listening. They are politicians in essence, and they are listening to their membership, who, in strange ways, talk about therapy in one way and do it in a very different way. So, as I said earlier about the staff meeting, if you go, what do they talk about at a staff meeting when they bring up consumer material? The diagnosis and the treatment approach, and they argue over which particular treatment approach or drug, etc., should be given to this particular client. When those things matter very little, if anything at all, in terms of treatment outcome. So my sense is, in fact, that clinicians need to do something different. They need to have an alternate language and then talk to these politicians about changing the policies and changing the language of mental health practice.
Well, what would that alternate language sound like?
Well, in terms of accountability, which everybody's asking about, that would be ongoing measurement of outcome and factors that do matter in treatment. Let me give you an example of one of those. We've known for years, at least 40, that the relationship between the client, the consumer, and the provider of care is predictive of outcome. We also now know that if consumers are asked and able to provide feedback about the nature of the alliance, positive and negative, that those consumers are much more likely to stay until they achieve a good outcome in treatment and to have better outcomes as a result. If the consumer is able to feedback information to the system about their progress, whether or not progress is being made. Those two things together can improve outcome by as much as 65%. Clinicians, in that case, are free to use whatever treatment approach or techniques best fit them and that they feel and the client feels best fit the client. All they're asked to do is expose themselves to ongoing client feedback about the nature, the scope, the amount, and the success of the procedures being used in the treatment process. This is the alternate language, outcome and alliance language versus diagnosis and treatment approach, and all driven from the client's point of view, involving the consumer in reviewing the types of services offered.
That really does seem to be a language that could speak to policymakers and so on, since they are very concerned about outcome, or at least they talk like they are.
Well, and, the consumers are also quite interested in outcome. 3 recent surveys, one by the American Psychological Association, one by CAMFT, which is the largest mental health provider organization in the state of California, and one done last year by Psychology Today, all said the following, which is quite disturbing if you consider what I said at the beginning of the interview about how successful we actually are, which we are. And that is that, second to cost, lack of confidence in the outcome of treatment is the primary reason that potential consumers give for not going to seek the help of a therapist, even though they think they could use it.
And where do you think that lack of confidence in outcome comes from?
I think that it comes from our lack of interest in the outcome and our obsession with the process of treatment. We are overly focused on how we work, and consumers don't care. Much the same way you don't really care how your DVD player works. What you want is it to play DVDs. That's
Right.
the outcome you're looking for.
Yes.
This is something, by the way, that the drug companies know very well about. They know from, if you watch their commercials on TV, they're marketing the outcome. They're not spending tons of time talking about how the drugs work. They're showing you pictures of happy people with hard erections.
Yeah.
And that's what the consumer wants. They don't really care about the vasodilation involved. They don't care about that. They want to get to the end game.
Yeah.
What is in it for me? And we as a profession continue to fight with each other and fight with consumers about how we're going to work and whether or not they have a particular diagnostic. And let me give you another example. Every year, a study, usually done by the American Psychiatric Association, because they have the biggest investment in the of course the Diagnostic and Statistical Manual. It's the best-selling volume ever in the history of psychology and psychiatry. They will publish a study somewhere, an epidemiological study that says, we surveyed Americans, and 20 to 25% of Americans suffer from a condition listed in the DSM. And then, of course, the lament is, but only 5% of that group ever get any help. And then they offer the solution, which is always the same. We need to educate people about the benefits of treatment. So my sense is that we don't need to educate people. We need to highlight what the benefits are, and they are many. But instead, what do we keep doing? Marketing diagnostic groupings. If you go to the self-help section, it's all listed by which diagnosis you have or by the treatment approach. And what consumers want is better, happier, more fulfilling lives.
Yes. Scott, in your book, you really take to task the over-reliance on medications for depression and for other sorts of conditions. Can you talk about that some?
Sure. And before I do this, let me make a point that we're not suggesting that medication isn't helpful to some people. What we're questioning is, what is it and when? What is it about medication that may be helpful, and when is it generally helpful? So let me tell you about a study that's going to be coming out in the flagship journal of the American Psychological Association called the Journal of Consulting in Clinical Psychology. 2 researchers, Bruce Wampold and Jeb Brown, both members of our institute, which can be found on the net at www.talkingcure.com, have taken a look at real-world cases. So we're not talking about the highly selected population usually seen in a randomized clinical trial. So let me just take a second to talk about that, because everybody's talking about the RCT, the so-called gold standard of identifying which treatment approaches are best for which kinds of conditions and clients. When you do one of these studies, typically the people included in the sample are so highly selected that they never, ever look like anybody a real clinician would see in their clinical practice. For example, they may take people who have only been depressed for one episode in their life and have no other comorbidity. Now, at workshops, I usually ask, now, how many therapists, and I ask them to show by raising their hands, have seen a client who has only one diagnosis? And generally, no one raises their hands. And I say, that's right. These kinds of studies simply don't apply to the people you see whose modal number of diagnoses is around 3 or 4. So with that, the question is, what do we do with regard to medication? Because everybody believes, and certainly the television commercials seem to sort of promise lots of wonderful benefits if you take the medication. These two researchers, Wampold and Brown, go in, they look at real-world clients, as I say, they pull the data, and they look at a variety of factors that seem to affect treatment outcome. And this really ties back to what I'm saying about needing feedback from consumers. What they find is that prescribing clients a drug, and these were for clients who had anxiety or depression, post-traumatic stress disorder, and bipolar disorder, really made not much appreciable difference in the outcome, unless the provider of that care, in other words, the prescriber, was already an effective therapist. Are you with me here?
Yes.
In other words, the medication, the effect of the medication was in who prescribed it, not in what was prescribed.
Are you saying that the medication worked because the person was also receiving effective psychotherapy at the same time?
No. I'm saying this is a therapist effect. Some therapists we know from tracking outcomes are better at their work than other therapists. And if you put the medication in the hands of an effective clinician, then they got outcomes that were in some instances 10 times that of other prescribers whose work was not effective. So the ability to prescribe, and this is a very controversial idea, didn't make an appreciable difference. What made an appreciable difference was the ability to prescribe in the hands of somebody who was a good clinician, who was an effective clinician. Now, as radical as that sounds, it's the same in other branches of medicine. Not all surgeons are created alike. What you want is an effective surgeon, because them doing a new procedure are much more likely to do it in an effective way.
Now, are you saying it's because they're prescribing the right drug and that's what makes them effective? Or are you saying that they're a better shaman, that they're...
I'm saying that there's something about these people that makes them better at their work overall, whether they're prescribing or not. We think that there are a couple of characteristics of what we're actually calling these super shrinks. And these are people who seem to get reliably better outcomes. And here's what they are. They are open to feedback. In other words, they listen to what the consumer is saying, as opposed to rely on their ideology or treatment technology or training. So they're open to feedback. They're constantly saying, try this, did it work? What do you think? How can we nuance that in some way? Open to feedback. Number two, and it's related to number one, they're flexible in terms of their strategy. That is, they're not committed to any one thing. And the third thing is they are doggedly committed to the outcome. So these are people who are going to flexibly accommodate the consumer until they get it right. And if they don't within a certain period of time, they know their limitations, and they're trying to make sure that the person gets to somebody else or someplace else on the continuum of care.
This again sounds like relationship factors and therapist-client alliance.
I think that it has tons to do with that. And with regard to medication, we think that the issue here is that everybody believes one thing when in fact something else is true. The thing I think we continue to act like is that, well, if you're depressed, then of course antidepressants are the cure, or CBT. The reason being, at least the reason that's believed, is that we are addressing the underlying pathogenesis of the problem. When in fact people who are depressed, for example, they have no more or less serotonin at their synapses than other people. They don't. Plus, the drugs take 3 weeks to work. And yet, the serotonin at a person's synapses 20 to 30 minutes after taking an SSRI is the same as it will be 3 weeks later. So the drugs are not working simply because they improve serotonin at the synapses. It just doesn't work like that.
Boy, we could go on and on about this. It raises some very interesting issues.
Are you hearing me say that medication isn't effective?
No, I'm not hearing you say that, but I am hearing you say that whether or not it is effective, it depends upon who's prescribing it, in terms of that the relationship can somehow amplify or potentiate it.
Absolutely, and that is the key variable. That is the key variable. So I say to people, choose your therapist carefully. Find somebody who has good rumors and who does a lot of work with the people who are dealing with the same kind of situation that you're dealing with. And best of all, if they happen to be using the outcome tools that we make available for free to clinicians on our website. Mm-hmm. Mm-hmm. And I should also say, in relationship to that, there's very good news that there are agencies all over the U.S. and abroad, and there are 7 managed behavioral health care organizations that have either completely adopted this way of thinking about clinical work or are in the process of doing that.
Very good. I'm glad to hear that. One of the things that caught my interest in the book was you do this breakdown of what really works in psychotherapy. You've got a pie chart with, I think, 4 sectors, and You've already indicated the importance of relationship. But could you take us through that pie chart? Sure.
This is data that goes back, again, close to 30 years, and sometimes people say, in fact, I heard it at this conference that I was just at from some members in the audience, that, well, we don't really know what makes treatment work. The science really isn't there, when in fact the science is there. It just doesn't fit with this notion that we currently have, that somehow or other we're fixing a diagnosis, we're fixing an underlying pathology with our treatments. There are 4 basic common elements that seem to account for effectiveness, and get this, across treatment approaches. So whether you're doing CBT or EMDR or solution-focused or psychodynamic treatment, some of the variants of various psychological treatment approaches, these 4 factors are involved. One of them is the alliance. It generally accounts for between 30 and 60% of the variance, the variability in treatment effects. You've got allegiance effects, which is the therapist's belief in what they do, that contribute between 20 and 30% to the outcome. The therapist has to believe in their approach. And then you've got structure, model, and technique effects. So the treatment does have to have some structure, a start and an end, and something in between that the client likes, that it makes sense to the client. And you're talking about between maybe 5 and 10% of treatment effects. Then you've got this whole other area that researchers usually refer to that is the largest percentage, that are referred to as extra therapeutic factors that impact outcome greatly. And this is what the client walks in the door with. Their pre-morbid functioning, their environment, that they live in, the chance events that weave in and out of their lives.
You touched earlier on this next topic, I think, but maybe you could just say a little bit more about it, and that's the movement within APA to, quotes, manualize therapy. Maybe you can explain to our audience what's meant by that and what the current status of it is.
Well, and it's not exactly the official policy of APA, but it is everything but that. And this is the notion, again, that it starts with the idea that there are certain diagnoses and that they're related to outcome. And that for those diagnoses, we need to have a treatment approach for which there's evidence that it works. And since the assumption is that it's something in the treatment approach, we have to manualize, we have to make a cookbook of that approach so that people know how to follow it. The problem with this is, on a larger scale, this makes imminent sense to most people. It makes sense to me. It feels right culturally. If you're going to manufacture an automobile, you need to have a plan. So you can gather the raw materials, etc., and make the car to specification so that it drives at the end. What we're saying is that metaphor just simply doesn't apply. That analogy does not apply in psychological treatment approaches. But there are about between 100 and 125 different manualized treatment approaches, and in some states, actually, the legislatures have gotten together with the various professional organizations. The legislatures, of course, demanding accountability, and the professional organizations say, here's how we're going to give it to you. We will specify which treatment approaches work, and then we will provide a manual for that, and then what you can do is measure our adherence to that manual. And the result, of course, is that clinicians' hands are increasingly tied about what they can say they're doing in the room with their consumers. All of which sounds very good. Sounds like we're finally going to get some quality in the service, and all of which has little or nothing to do with the outcome of the treatment service.
So, for example, somebody comes in, they've got depression. It may be kind of dictated to them that they will use cognitive behavior therapy and, say, not hypnotherapy.
That's exactly right, or psychodynamic, and regardless of what the client says they really want to do. Now, here's what good clinicians do. So we're talking at two levels here. We're talking at the policy level and the accountability level, and then we're talking at the actual practice level, because clinicians, for the most part, pay attention to the consumer seated in the room in front of them. And it turns most clinicians, and maybe I'm telling tales out of school here, and somebody will call and get me in trouble, but the truth is most clinicians are turned into liars this way.
Yes.
What they do is they do one thing in the room with their consumer that they think is best and the consumer is demanding, and then they do another thing on the paperwork.
Right. In the subtitle of your book, you advocate for client-directed therapy, and you've talked about the importance of relationship factors and so on. How is this different than the client-centered therapy that Carl Rogers championed in the late 60s and 70s?
Well, in many ways, we're standing on the shoulders of great thinkers and practitioners like Carl Rogers that place the alliance or the relationship between clients and therapists at the center of the work. When we mean something a bit different from client-directed, we mean literally putting the client in the driver's seat, evaluating the outcome and the relationship rather than the therapist. Because the outcome rests in that the outcome is truly in the eyes of the beholder. And interestingly enough, when we integrate the client's feedback into the service, not only did I reflect feelings and address your negative thinking, but I asked the client, did it help you, and is this what you wanted to do? That feedback is what leads to better retention and outcome in the treatment services, which again is what most therapists do in their offices behind closed door. They don't do therapy by the book. No therapist I know does therapy by the book. Instead, what they do is they accommodate their knowledges to the individual in their room based on their generally informal assessment of the client's response. What we've advocated is a formal assessment of the client's response. We're literally asking the client for feedback and integrating that into the treatment. And that's where the research, I think, is so interesting and fascinating. Just doing that encourages changes in that relationship that lead to better retention rates. In other words, the clients don't drop out. And by the way, I should say, dropouts are in fact the scandal of mental health and substance abuse treatment in the United States. Not our outcomes. Our outcomes are great for the people who stay, but about half of the people who go terminate unilaterally, that is without informing their therapist, by very early in the treatment process. And then, again, the second piece is improving the outcomes by as much as 65%.
I think you also refer to your work as solution-focused therapy. Now, I recently had Bill O'Hanlon on as a guest. I assume you know him. To what extent has your work been influenced by him, if at all?
We don't refer to our work as solution-focused. I spent my youth as a therapist working in Milwaukee with people who really started solution-focused therapy, Steve DeShazer and Insoo Berg. I was there between 1988 and 1993. And the difference between what we were doing then and what we're doing now, and I think what Bill is talking about, and many others, is that they are very much interested in how to do therapy. And I'm not interested in that. I'm interested in whether or not consumers think that therapy is working and how to let therapists know when it's not. So we are offering a much more of a meta model to treatment rather than a model of therapy. Frankly, it does not matter if the therapist is being solution-focused, cognitive, or psychodynamic. What matters is, does the client like it, and are they getting better? That's what matters.
Yeah, that's really interesting.
Now, sometimes people hear this and say, well, it obviously doesn't matter what treatment approach, I don't need to learn anything, which I would say is a mistake in the opposite direction. I think therapists need to be exposed to a wide variety of ideas because the clientele that we're seeing nowadays is diverse, and their ways of thinking about their problems and how to solve them are equally diverse.
Yes. I've also had a couple of recent interviews with people in the positive psychology movement, and you emphasize enhancing client resources and client strengths. So it sounds like your approach would fit into their rubric or their rubric would fit into yours. What's your take on the positive psychology movement?
Well, I have a couple of feelings. We have a chapter on client-directed work in the volume. I think it's the Handbook of Positive Psychology that just came out.
Oh, really?
Yeah. My sense about all of this is that whether it's positive or negative is not the issue. Whether we're focused on clients' resources or their deficits is not the issue. This takes us back down to a very low level of abstraction to the how-to pragmatics of to do therapy, whether you're going to highlight strengths and resources or not. Now, again, from the average clinician's point of view, I don't find any clinicians that are entirely deficit-based or entirely solution or positive-based. Mm-hmm. I find therapists who are mixing those things because that's what day-to-day clinical work really requires, figuring out what works for the individual, not what the appropriate ideology is for the field as a whole. So whether, again, positive or negative doesn't matter to me. What matters to me is if you're approaching the client from a position of strengths and resources, which have in many ways been ignored by the field of psychology and psychotherapy in general, does the client like that? And are they getting better?
Okay.
The bottom line message to all this is relatively simple. And let me just say one other thing about that. This is an idea that when I presented to business people with a business background, they kind of nod their head and say, and this isn't a surprise to them. Mm-hmm. Because they are dependent on consumer feedback. If you call Dell, their customer service line, you're going to get a survey at the end. They're interested in this because they know that clients who are dissatisfied, not satisfied, but dissatisfied, are much less likely to call Dell back again and buy another Dell product. They would like to have a better customer service mentality, and this is all we're trying to bring to the field of psychological treatment.
Interesting. Are there ways in which your involvement with psychology and psychotherapy have impacted or helped you in your own personal life?
I don't.
I know I kind of sprung this on you without any
I'm just
preparation.
Trying to think. I love what I do, and I feel passionate. I hope that comes across.
It definitely comes across.
In writing about and talking about these ideas. I suppose that in my own work, the idea of feedback is critical, that I spend about 100 or more days on the road every year doing trainings and workshops and consultation, and the feedback of the people in the audience is critical to fine-tuning and making what I hope are presentations superior to any other presentations they might go to. So in that way, I think this has affected me. I think as a young person being interested in psychology, if that's what the question is aiming at, I was and originally when I went to university, I started as an accounting major. And I was raised in a family that didn't have much money, but my mom thought that maybe if I could count other people's money, I'd at least be close to it at some point in my life. But then I did, like many people do, I took an undergraduate course, a GE course in psychology, and I met a guy named Hal Miller, who was one of Skinner's students. And I don't know that it was psychology that I became so much interested in as it was Hal Miller. I wanted to be like him. I wanted to think like him. I wanted to have the depth and breadth that he conveyed in his lectures. And that really was a tipping point for me. I changed my major within one semester and began to work much more closely during my undergraduate career with Hal Miller. That really, it had a profound impact on me personally.
Well, thank you for sharing those personal insights. We do have some students who follow this series and think they're always interested in how people get into psychology and wind up in the careers in which they do wind up.
Sure.
And it's interesting that you started out with that focus on accounting. And in some ways, it seems like the work that you're doing now is still kind of this meta level that you're working at. Seems like it has some resonance with that to me.
Yeah. Yes, I think it does, interestingly enough.
Yeah. To wrap things up, what's your advice to our listeners in terms of finding a good therapist or a counselor? I know that's one of the ending chapters that you had in your book.
Well, a couple of things. The first one is that don't think about finding a therapist. look for a variety of therapists and call them and talk to them, interview them with some very specific questions over the phone. Let me give you some examples of that. And if the therapist will not spend 10 minutes with you on the phone, then this is not somebody that you want to see. For whatever reason. They may be the greatest therapist in town, but if they don't have 10 minutes to talk with you about what they're going to do, then my rule is you don't go see that person, because they're not going to have 10 minutes in between visits to talk with you if your therapy is not going the right way. Mm-hmm. The second thing I would do is when talking with them, I'd want to describe the situation in clear, concise terms that you want help with, and ask them, how many cases like this do you see a year? And I want to see somebody who does this a lot. I want to see somebody who has a lot of experience working with my kinds of cases. And number two, I want to know, how do they know whether or not their treatment is working? Do they have some formal assessment that they use for making sure that it works or not? A third thing is to look for referrals from friends and family that have had successful experiences.
Yes.
With therapists in the past. But here again, I'd be cautious and careful. You've got to find a therapist that fits for you, and that may mean you have to go through 3 or 4 people, unfortunately, at the present time, before you find somebody that really works for you. Fourth item is to know that if a particular therapist working in their way is going to be of help to you, you should begin to experience some resolution of your problem or feelings, whatever, within weeks rather than years. So you should see some light at the end of the tunnel. I'm not saying you feel completely better necessarily, but you should start to feel something within the first 4 to 6 weeks. If you don't, then it's probably an indication that you need to talk with that therapist about adjusting what they're doing. And when I say adjusting, I mean adjusting either the type or the focus of the treatment, or involving additional resources. Going to see the psychiatrist, perhaps, going to a group, augmenting with reading material, homework assignments, etc. If you don't see any change by the 8th to 12th week, then chances are that this relationship between you and this provider is not likely to lead to change over the long haul, and you'll want to get to see somebody else.
Okay, that's great. Finally, I want to mention that you have upcoming workshops in Los Angeles on Friday, January 5th, and in San Francisco on January 6th. Who should attend those workshops, and what will they learn?
I would say psychologists, social workers, marriage and family therapists, anybody who is doing direct clinical service. That's the group we're going to be focusing on. And we're going to be talking about how to improve the outcome of the clinical work you do with your most challenging cases. Mm-hmm. And the contact person is a guy named Bob Cassidy. His email address is bob@rcassidy.com.
Okay, and I'll also put a link to the registration website in the show notes on my own website.
That'd be great.
Scott, thanks so much for being my guest today on Shrink Wrap Radio.
My pleasure.
I hope you enjoyed this conversation with Dr. Scott D. Miller. I'm very grateful to Dr. John Drimmer, psychologist and Shrink Wrap Radio listener, for drawing my attention to Scott Miller's work. I highly recommend his book, The Heroic Client, and I hasten to add this is not a paid endorsement, in case anyone is wondering. One of the things that stands out for me in the book and in our discussion is what a small part the therapist's school of thought contributes to overall effectiveness. This finding is based on a meta-analysis of 40 years of research on therapy. The term meta-analysis refers to reanalyzing not just a single study, but all of the relevant studies covering a certain span of time. So when they take an overview of 40 years' worth of research on the results of psychotherapy, there are some startling things that leap out. The first is that therapy does work, and the next is that the particular brand of therapy doesn't count for all that much. This is a surprising finding because every year, it seems, there are new books coming out in which someone claims to have found the ultimate cure. The most flagrant example of this within my memory was Arthur Janov's 1970 book, The Primal Scream, which bore the modest subtitle, The Cure for Neurosis. Not a cure, but the cure. Now hardly anybody who wasn't an adult at the time that book came out has ever even heard of primal scream therapy. However, Scott Miller's research really highlights how little it matters whether the therapy is primal scream or Rogerian or Freudian or cognitive behavioral or what have you, as much as it matters that the therapist believes in it and is able to effectively transmit that belief. This is why I use the word shamanism, but Scott didn't react to that. Perhaps he didn't get what I meant by that reference, but longtime listeners will recall that I believe that much of therapy is shamanism in the sense of a designated person of wisdom working within a strongly held belief system, performing certain healing rituals, and if the client shares that frame of reference, healing stuff is likely to happen. Or so I think. There is a tendency for therapists and for clients seeking therapy to get really attached to a particular brand or style of therapy. Scott Miller argues that it's best for the therapist to be conversant in multiple approaches so that he or she is more likely to be able to adapt to the needs of individual clients. The research of Scott and his colleagues suggests that it's time for therapists to be less attached to theoretical dogma, to focus on the client and really listen to the client rather than trying to figure out which DSM template they fall into, and to solicit feedback from the client on how things are progressing. Do you recall the part of our discussion where Scott said that the effectiveness of medication depends on the effectiveness of the therapist who is prescribing it? For me, this was very reminiscent of some research described in Malcolm Gladwell's amazing book, Blink. I don't have a copy here and may not get it exactly right, but I seem to recall him describing a series of studies on the effectiveness of medical physicians. They found that judges could quickly figure out which doctors would be effective just by listening to a couple minutes of their speech. They even applied special filters to the speech so that the words could not be made out, but there was something in the tone and the rhythm that communicated caring and trustworthiness. I recall also that a key factor was whether the doctors were willing to take the time to listen to their patients. So in the end, we're reminded that effective therapy comes down to such human factors as love, caring, listening, and belief, and the ability of these qualities to potentiate the client's self-healing.
You're on the couch again with Dr. Dave. And Shrink Rap Radio is playing on again. Yeah, it's all in your head. It's all in your head. Shrink Rap Radio. Shrink Rap Radio. Shrink Rap Radio. Shrink Rap Radio. It's Shrink Rap Radio. All the psychology you need to know and just enough to make it dangerous. It's all in your head.
Once again, our sponsors are Podshow, which you can check out at podshow.com, and GoDaddy, where you can get a discount by using our discount code of SHRINK3 at checkout when you buy a new domain name. You'll find other GoDaddy discount codes at shrinkrapradio.com. A custom domain name can make a wonderful surprise present for the holidays. Just think you could get www.auntmaud.com or www.unclebillybob.com for only $6.95 for a whole year. Speaking of Christmas gifts, you can now purchase the first 50 Shrink Rap radio shows on 2 MP3 CDs. The first has shows 1 to 25, and the second shows 26 through 50. The CDs are $12 each or $20 for both of them, and you can get them at www.poddisc.com. That's PODDISC.com. And, not everybody is up to speed on this podcasting thing, so giving it to them on CDs might make a nice gift. Thanks to all who have taken our listener survey. We've finally made it to 100 surveys. In fact, we're up to 105. Thank you so much. Now, of course, this doesn't mean I don't still hope to drive it higher. The more people we hear from, the more accurate the survey becomes. Plus, you've been giving me great ideas for future guests and topics. So if you haven't filled it out yet, please do so. You'll find it at shrinkrapradio.com/survey.htm. And there's a link on the Shrink Rap Radio website as well. And for everybody who completes the survey, includes their name and email address, I'll send you a link to a radio talk on dreams I gave before a live audience at the University of New Hampshire. We have 8 new additions to our Frapper map. I want to give a big thank you and welcome to Say It Isn't So in Mission Viejo, California, Angie and Jindabeen. I'm sure I didn't get that quite right, but it's in New South Wales, Australia. Rachel in Paris, Ile-de-France. Remember that. And Stephen in Brooklyn, New York. Shell in Hawaii. Jim in Melbourne, Victoria, VIC, does that stand for Victoria? Australia? I think VIC must stand for something else. And Drew in Los Angeles, California. And finally, Travis in Maple Valley, Washington. So we keep going with our Frapper map, and you can add yourself to it. All you have to do is go to frapper.com/shrinkrapradio, or you'll find a link to it on our website. And you'll be entered into a drawing for a free copy of a book I co-authored. And I said I would do that at the end of the year, so that will be later this month. I will be announcing the winner of that book.
Hi, everybody. This is Sylvia from LA, and you're on the couch, on a rock, on a boat, on a plane with Dr. Dave.
And with that very wonderful transition from Sylvia in L.A., it's time for us to dip into our mailbag of recent listener emails. First, we hear from John in Las Vegas, who first wrote saying he'd like to take my class in positive psychology if I do end up offering it. I sent him a reply to that and also urged him to take our listener survey, whereupon he replied as follows: Dr. Dave, I was in the original 11 survey takers. So, John, I'm sorry for having missed that. He went on to write, Las Vegas is only temporary until I get my BSN, which I think stands for Bachelor of Science in Nursing. And he notes that it's 8 months, 3 weeks, and 4 days, I guess, till he graduates. He says, I want to get away from nursing. I did a clinical I think he meant internship, at the Nevada State Mental Hospital, and it was much more my speed, but still not exactly what I want. I don't like pushing drugs and cleaning butts, he says. This is why I'm so interested in your program. Since I'm slacking off on studying for my finals anyway, I have a question for you as a professor, even though retired. What do you think I should do as far as getting into psychology? It's a given I'm going to do psych nursing, but I want to go beyond this. Do you think I should get into a master's program first, or do you think I should go for the Ph.D. right off the bat? Really, my question is about time. A master's degree takes 2 years, and I guess you can be a therapist with that, right? Ultimately, I want to get the Ph.D. anyway, so would I save time by biting the bullet and trying to get into a doctoral program right away? Yeah, like it's that easy, I know. Should I apply to both? Well, let me answer right here, John, and insert my answer. Yes, and I want to answer on the air because there may be other people in a similar boat who are trying to decide about, whether to get a master's or go straight into a PhD program. My advice is go straight into the PhD program. Taking 2 years out to do the master's degree will definitely add extra time. You can pick up a master's on the way to the PhD. Most PhD programs will grant you a master's after the first year or two as part of their own program. The other thing is, after you got the master's, you would not be able to start practicing right away because then you would have to focus on licensing, and licensing would probably take you another 2 years. So you would definitely be well advised to go right into a doctoral program. Back to his letter. He says, also, what areas should I concentrate on? This is my vision for my career, helping people achieve harmony, health, and then a sense of meaning, accomplishment. I want to work with also creative people, such as musicians and writers, to help them increase their creativity. Do you know anything that sounds like this? Cognitive behavioral therapy sounds promising, and obviously positive psychology, although this is not a clinical degree. If you have any ideas, they will be appreciated, however brief. I know you're busy. Thanks. See you, John. And I did write back to John, and I suggested several schools in the Bay Area, including the California School of Integral Studies, a Saybrook Institute, I might have mentioned the Wright Institute, and the Institute for Transpersonal Psychology, as all having reasonably flexible programs in which he might be able to direct himself specifically to those areas of interest that he mentioned. Also, educational psychology can be a good backdoor into working with people, because clinical psychology programs are about as hard to get into, I've heard, as getting into medical school. Very competitive. Everybody wants to be a therapist. So educational psych is a good backdoor in. And also organizational development is another great way to be working with creative people, very bright people, and people within organizations, whether they're corporate or nonprofit. So he replied to that set of advice in another email saying, thanks, Dr. Dave. I appreciate your time and insights. I'm from the Bay Area, San Bruno, and would love to go back, except it's too expensive. And boy, do I ever know what he's talking about. He says, I have a wife and one child and one in the oven. So $1,500 a month rent for a studio apartment is not really in the cards. And believe me, it can cost that much in the Bay Area. Nonetheless, I will take a look at all of these programs and weigh the pros and cons. So thank you for the new lines of thought. What have you heard about Canadian schools? Is it true that they are considered inferior to U.S. psychology clinical programs? I find this hard to believe. Well, I have to say I find it hard to believe, too. I've never heard that. If anything, I think that the Canadians are likely to be totally rigorous, maybe even more so. So I wouldn't worry about that. He also asked, what are your personal thoughts on Psy.D. versus Ph.D.? Now, Psy.D. stands for Doctor of Psychology, and Ph.D. stands for Doctor of Philosophy. He writes, I know the Ph.D. has more research, but does Psy.D. have more clinical experience to fill in the void? And the Psy.D. was developed maybe 15, 20 years ago as an alternative for people who really wanted to focus on clinical practice and who didn't want to have to do the major piece of research that the PhD typically requires. And so there are various programs around the country that have Psy.D. programs. If you plan to go on to be a university professor, then I think it's important to go to a PhD program. If you plan to be a clinician and you know that you're never going to want to be a university professor, then I think the Psy.D. is a perfectly good way to go. There'll be less emphasis on research and, yes, more emphasis on clinical experience. He ended his email with, he says, I have to put a muzzle on myself. Sorry for talking so much. It's just you're the only clinical psychologist I know. Thanks, John. Well, hey, here I am. I'm the clinical psychologist that you folks know. And if you've got questions, I'm happy to answer them. Our next email comes in the form of a voice message left for me on Skype.
Hello, Dr. Dave. This is Mark Hammond calling from Chambersburg, Pennsylvania. I'm just calling to let you know that I'm enjoying your podcast. Currently, I'm listening to the podcast on depth psychology with Stuart Kohler. I've listened to your podcasts over the past several months. With the downloading of the podcast, it gives me the opportunity to pick and choose which ones I care to listen to in the order that I like to listen. And I just wanted to call and let you know how much I appreciate your efforts in producing these podcasts. Thank you very much, and I've enjoyed speaking with you.
Mark, thanks so much for leaving that email message. I really appreciate it. And I think with that, we'll wrap up our email for today. We'd love to hear from you. You can send your emails to shrink@shrinkwrapradio.com. You can leave voicemails on Skype. Our name there is ShrinkPod. Alternatively, you're encouraged to leave voice messages on MyChingo, and you'll find a link to that on our Shrink Rap Radio website. Or you can leave a phone message in the U.S. by calling 206-888-2746. Help us grow the audience for our show. We're always trying to do that, and your help will be deeply appreciated. I don't know how many of you will have noticed, but at the end of last week's show, I had announced that I would be interviewing a sports psychologist colleague on today's show. Unfortunately, he changed his mind about doing the interview. However, I'll be keeping my ear to the ground for someone else in that branch of psychological endeavor. And in any event, Dr. Scott D. Miller gave us a very stimulating interview for which I am most grateful. And I want to let you know that our next show will be about Jewish mysticism and the Kabbalah with psychologist and rabbi Dr. Abner Weiss. That's it for now. This is Dr. Dave saying, it's all in your mind.